Hi guys! We chose to do chapter 17, the sleep physiology and its relationship to the cardiopulmonary system. My name is Holly Davis, and my other group members are Seth and Claudia. Hope you enjoy our presentation.
Hello, this is Seth Hernandez, and I'll be going over the different types of sleep as well as the sleep cycle itself and the different steps. So, two really important major types of sleep that we're going to be going over is non-rapid eye movement, non-REM sleep, and rapid eye movement, REM sleep. Starting out with our first two stages of the sleep cycle, we have the eyes open awake stage W. This is when this type of sleep stage is very similar to REM sleep. Your EEG is going to show beta waves, high frequency, low amplitude, and you're also going to see those pretty characteristic sawtooth waves. And the next one, you're going to be in the eyes closed wake stage. So you're going to feel really drowsy. This is kind of when you feel really drowsy. The EEG is going to be characterized by mostly alpha waves, and then the EOG is also going to show some slow rolling eye movements. Next up in our sleep cycle is the actual non-REM sleep, or as we like to call it, the N sleep. It consists of three different stages: stage N1, N2, and N3. N1 and N2 are known as the light sleep stages, and N3 is also known as the slow wave and deep sleep stage. These three stages account for around 75 to 80% of sleep time in average adults, which is a pretty big portion of our sleep time. And all these three stages pass during the 30 to 45 the first 30 to 45 minutes of sleep. So let's dive into that first stage, stage N1 of the non-REM sleep cycle. So the first stage is going to be a transition stage between drowsiness and sleep. So during this time, the person may experience hypnic myoclonia, which is basically just involuntary like muscle twitches while you're falling asleep. And the EEG is going to show light sleep, low voltage with some alpha waves and theta waves as well. The alpha waves are going to usually appear when the brain is more in a calm and relaxed state, and you might also see some beta waves, and then you'll see some vertex waves as well toward the end of the N1 stage. Now, moving on to the next stage, the N2 stage. This is known as obviously one of those light sleep cycle stages. The EEG is going to be pretty irregular and comprise mostly of those theta waves, which are between 4 and 7 hertz, and then you're going to have some sleep spindles and one or more K complexes as well. You're going to see some vertex waves sometimes, and the EOG will depict some slow and absent eye movements. And this is the portion of sleep that takes up the most amount of time. It's 40 to 50% of it. So moving on to our last stage of the non-REM cycle, stage 3. So stage N3 is usually split into two main categories. You have your slow wave sleep and your deep sleep. So during your slow wave sleep, it's going to be present with 20 to 50% of the EEG activity is going to be high amplitude, so greater than 75 millivolts, and then slow frequency. There's going to be slow frequency, so 2 hertz or slower. Delta waves, and then there's going to be sleep spindles and K complexes that may be present as well. During deep sleep, 50% of the EEG activity is going to consist of delta waves, and there is going to be little to no eye movement, as well as the EMG showing little or no electrical activity, and your heart rate and your respiratory rate are going to decrease 20 to 30% during this time, and this part of sleep is extremely important for your mental restoration, which is a really big thing. Now we're going to move on to REM sleep, which is rapid eye movement sleep. So this is going to be during your eyes open awake stage, which is also known or characterized as paradoxic sleep. Your EEG is going to show low voltage, mixed EEG activity, and you're going to see those frequent sawtooth waves that are pretty characteristic to it. There might be alpha waves present as well. This is the part of your sleep cycle where most of your dreams occur, and during this time you usually have temporary paralysis of most of your skeletal muscles. It is not as restful as a state as your non-rapid eye movement sleep portion, but it is still restful. And this slide is just a great summarization of the sleep cycle itself. Starting on the left, we have the eyes open awake stage, the eyes closed wake stage, the stage N1 light sleep, stage N2 light sleep, stage N3 slow wave sleep, stage N3 deep sleep, and then we have that rapid eye movement stage. And I am also going to go over the functions of sleep. So there are two basically widely accepted purposes and functions of sleep. They're both restoration and energy conservation. So during sleep, there is a promotion of physical growth and healing, as well as during that portion of slow wave sleep. That portion of slow wave sleep coincides with the release of a growth hormone in adults and teenagers as well. So that's why we connect restoration with sleep, and the other portion of that is energy conservation. So a lot of people think it's just an extension of homeostasis, and during our increased workload, our increased energy during wakeful hours, the decreased energy in our hours of sleep seems to be just an offset of that increased energy we use during our wakeful hours.
Next is about the circadian rhythm. The circadian rhythm is a biological rhythm that occurs every 24 hours. It includes sleep-wake cycles, changes in cortisol levels, and your body temperature fluctuations. There's also something known as circadian synchronization, and this is when an individual's biological clock corresponds to a good sleep-wake pattern. So moving on to sleep debt. Sleep debt is the number one sleep-related problem currently. Sleep debt is when the amount of sleep that is needed every night to maintain normal functioning is not met. So this could be an hour or 3 hours, just depending on what every individual's amount of sleep that they need and then how much sleep they actually get. Now, to determine the total size of the sleep debt, you add up each number of hours lost every night to get the total size. Now, depending on age and life stage, there are different types of sleep patterns for that age of life you're in. So starting at youngest, for infants, newborns, they do require about 16 to 17 hours per day. Now, this isn't just all at once. It's split up into about 7 sleep periods, where 50% is REM sleep and 50% is non-REM sleep. At 4 months old, hopefully, most infants sleep through the night, and at about 1 year, most infants will sleep around 14 hours a day, and they'll take 1 to 2 naps. Now, the next age group, toddlers, at age 2, they should be getting about 14 hours of sleep per day, and when they age up between age 5, they should be around 12 hours a day, and this is simply because we have eliminated the amount of naps they're taking, so the sleep decreases. And for toddlers, they spend about 30% in REM sleep, and they have a really high slow wave sleep. Moving on to the next age group, children and adolescents. Children and adolescents both get about 20% of REM sleep. School-age children should get anywhere from 8 to 12 hours per day, and adolescents should get about 8 to 10 hours. Now, for young adults, it's recommended for about 6 to 8 hours of sleep per day, with again 20% of REM sleep. However, N3 will decrease and the number of sleep arousals will increase, which may lead to less qualitative sleep. And then again, for older adults, it should be about 6 to 8 hours per day. This time they might get a little bit more REM, so anywhere from 20 to 25%. And in this one, N3 is significantly reduced or absent, which could also be due to more sleep arousals, as we will discuss later. This is just a broad overview of some of the factors that affect sleep, and we're going to jump into them a little bit more in depth on the next slide. So as we just discussed, age can also affect your sleep. Depending on your age group, the amount of sleep you need can vary, and that plays a big role in how much sleep you get. The environment is also something that can affect the sleep, whether it's noisy or too hot, too cold, whether there's too much light. All of those things can affect falling asleep and staying asleep. Another thing to mention is any emotional stress caused by work or physical stress caused by the lifestyle you're working. All of that can affect sleep. Again, staying asleep or falling asleep. But also, fatigue is something that can encourage going to sleep because you are just so tired. Now, when it comes to alcohol, stimulants, and medications, those all have an effect on sleep as well. Some medications have side effects such as insomnia, nightmares, drowsiness. So, just depending on the medication, it can affect the sleep, as well as stimulants. So, one of the stimulants being caffeine. We all love a good cup of coffee. Caffeine stimulates the central nervous system and will make it harder to fall asleep, where alcohol can disrupt sleep and cause nightmares sometimes. And specifically smoking, some smokers consider themselves to be light sleepers, and this is because they have difficulty staying asleep, which is due to the nicotine. And finally, something I thought was really interesting was when it comes to diet, weight gain can increase the amount of sleep while weight loss can decrease the amount of sleep that you're getting. So it's really important just to see all the different factors, even how much motivation you have to sleep can affect how much sleep you get, and also the quality of the sleep, which is really important to remember. So now discussing a couple types of common sleep disorders, starting off with hypersomnia. Hypersomnia is when you have periods of deep sleep for a really long time or an abnormal amount of time. Now, hypersomnia is typically caused by psychological factors more often than physical factors. And to really identify it, it's when you wake up, you're in a state of confusion, you have extreme drowsiness, and sometimes it's also given with differential diagnoses of sleep apnea, self-imposed sleep restriction, medication effects, periodic limb movement disorders, or circadian rhythm disorders, which all affect the sleep cycle clock internally that you have. Now, on the other end of that is insomnia. Insomnia is the most common sleep disorder, and this is when there is an inability to fall asleep and or stay asleep. There's a couple different types. With transient insomnia, it's when it's less than a week of insomnia. Short-term insomnia is anywhere from 1 to 3 weeks, and chronic insomnia is greater than 3 weeks. So current research is showing that people with insomnia are hypermetabolic, which I thought this was pretty interesting to learn, as well as insomnia tends to affect more women than men, and it does increase as you age. Moving on to narcolepsy. Narcolepsy is a hereditary disorder which is typically described as several sleep attacks that happen throughout the day. This is a type of hypersomnia. Now, the attacks that happen throughout the day can happen for several seconds or maybe more than 30 minutes. Everyone's just a little bit different. Some people with narcolepsy may experience cataplexy, which is the loss of muscle tone and paralysis of voluntary muscles that are triggered by emotion. They also might have temporary paralysis when they wake up from one of the sleep attacks, and they could also have visual or auditory hallucinations. Narcolepsy typically begins, you start seeing the symptoms in adolescence or young adulthood, but there are also non-hereditary narcolepsy, and this is typically seen after a cerebral trauma, so it's called post-traumatic narcolepsy. Moving on to PLMD, or periodic limb movement disorder. PLMD is the repetitive stereotype movement of the legs during sleep. This is a very rhythmic pattern that occurs 30 seconds apart from one another. PLMD, typically this movement is happening during non-REM sleep, and it is more often to see in older adults. It's also often seen in patients with restless leg syndrome. So restless leg syndrome is RLS. It's the intense, unpleasant sensation anywhere between the knees and the ankles. So it's been described to be a crawling sensation, painful, cramping, burning, a knife-like, aching, really, really painful adjectives have been used to describe these pains while you're sleeping. And no one wants to be in pain while they're sleeping. So it causes a strong urge to move your legs to relieve that feeling. This is also seen more commonly in older adults. And interestingly, it's associated with iron deficient anemia, and it can be exacerbated by pregnancy, caffeine, diabetes, or even renal insufficiency. I feel like a lot of people are now talking about sleep apnea, and that's because it's pretty common. Around 18 million people in the US have sleep apnea, but a lot of them don't even know that they have it. So, what is sleep apnea? Sleep apnea is the temporary cessation or absence of breathing while you're sleeping. This is the loud snoring, the gasping of air, all of that while you're asleep. It's typically found in people who are obese or overweight. And the next morning, these people typically are really sleepy and are very fatigued throughout the day. Now, there's 3 different types of sleep apnea. The first one is obstructive. This is just that. There's an obstruction in the airway that affects the airflow of air through the nose and mouth. But with obstructive sleep apnea, there are still respiratory efforts from the diaphragm and intercostal muscles. Now, central sleep apnea is the opposite. So that's when there's no respiratory efforts through from the diaphragm or intercostal muscles. And then mixed is just that, it's a combination of the two. So at first, the cessation stops because of the respiratory effort, and then after that, it's followed by a period of an upper airway obstruction. So like I said, it's really common, but a lot of people don't know that they have it, and this is because the only way to be diagnosed is with a sleep study, which is also called a polysomnography. So this test is typically done at a sleep center, but now they're coming out with at-home studies. And my mom's actually a sleep technologist. That's part of the reason why I chose this chapter to do, because I find it really interesting. She knows how to read all of the brain waves and all of that. And sleep is very important for you. But not a lot of people take care of it, and I'm one of them. So moving on to obstructive sleep apnea, we're going to dive into it a little bit deeper. So obstructive sleep apnea, like I said, is one of the most common types of sleep apnea. It affects about 4% of men and 2% of women. Now, obstructive sleep apnea is when the person tries to inhale during a period when the upper airway muscle tone is reduced. So this causes a negative pressure, and this negative pressure causes the pharynx to narrow. When this happens, the tongue is sucked back into the oropharyngeal area, causing a blockage. This is when you hear a loud snore and then it's silent. And then there's a loud snore at the end. Typically, this is when people can even wake up to sit up and gasp for air because there's no air. They're not breathing. That's what the silence is. Now, sleep apnea is when this is a cycle that's repeated hundreds of times a night. And when you get a sleep study, that's what they study. They study how many times a night you're having these episodes. My stepdad is a heavier set man, and I know when he first had a sleep study done, he was having anywhere from 70 to 300 of these episodes at night. So it's really important for your body you're depriving your body of oxygen when you have sleep apnea. So we'll get into some of the treatments on how to fix that on the next slide. Now, because you're depriving your body of oxygen, because you're not breathing while you're sleeping, you are having a low O2 concentration. So there are lots of effects this can have. This can cause a morning headache. It's even been seen to show a cognitive function decline, high blood pressure, irregular heart rhythms. You're 2 times more likely to have a heart attack and 2 to 3 times more likely the frequency of strokes. And there's even a loss of interest in sex due to the lower oxygen levels. Something I found really interesting but makes a lot of sense is people with sleep apnea are 7 times more likely to get in an automobile accident. And this makes sense if you're on the morning commute, didn't get a good night's sleep, and you're not fully paying attention because you're so tired. I thought that was really interesting. Now, sleep apnea, you're not breathing. If you're not breathing, a lot of your body is suffering. So sometimes it can lead to complete respiratory failure or even sudden death. Something also that's important to know is that stroke patients have an increased risk of having sleep apnea, worth a 60 to 80%. The treatment for obstructive sleep apnea is continuous positive airway pressure, which is also called CPAP, a CPAP machine. A CPAP machine prevents the collapse of the airway, and this is because of that positive pressure. It's taking away that negative pressure that causes the pharynx to narrow and collapse. Now, because this is all about the obstruction, it's not indicated for those that have central sleep apnea, because central sleep apnea has no obstruction. So some of the risk factors for sleep apnea, specifically obstructive sleep apnea, are weight, obesity, being overweight, having a large neck size, any chronic nasal congestion, hypothyroidism, hypertension, any craniofacial abnormalities, if you have a family history, alcohol, smoking, if you have diabetes, enlarged tonsils, and even race. So it was seen that Blacks, Hispanics, and Pacific Islanders are more at risk of developing sleep apnea than Caucasians. And then for central sleep apnea, the risk factors are less based on weight and more physiological. So age and male sex, those are sort of kind of both for both sleep apneas. But specifically with central sleep apnea, you have atrial fibrillation can put you at risk, congestive heart failure, history of stroke or brain tumor. Also, if you're at a high altitude or you have opioid usage history, those can all put you more at risk for central sleep apnea. And this is just a diagram showing, the diagram on the left is showing what sleep apnea is, where you have the obstructed airway, where the tongue gets sucked back and there's no air being able to flow through because of the negative pressure that's there. And then the image on the right is a patient wearing a CPAP mask. So it goes all the way around the head. It has a nose piece, and this nose piece causes a positive inflow of positive pressure, which will keep that. You can see that the tongue is in its normal position and the airway is completely open for air to flow through.
Hello, my name is Claudia, and today I'm going to be talking about the normal cardiopulmonary physiology during sleep, and we're going to start off with the musculoskeletal system. So we're going to start off with the somatic skeletal muscles usually have the highest muscle tone during the wakeful state. The muscle tone decreases while with sleep onset and throughout non-REM sleep. Muscle tone is at its lowest level during REM sleep. During REM sleep, neural impulses to most skeletal muscles stop, and a lack of muscle tone ensues. In essence, the sleeper becomes temporarily paralyzed. This is especially true for the muscles of the back, neck, arms, legs, and posterior muscles of the pharynx, including the genioglossus muscle, the infrahyoid muscle group, and the palatal muscle group. The partial paralysis may allow the tongue to fall into the back of the oral pharyngeal area during inspiration. So this sometimes can lead to obstructive sleep apnea. And some of the less affected muscles are like the eyes, the muscles that move the eyes, the diaphragm. This explains in part why the sleepers do not physically act out a vivid dream during REM sleep, such as running from someone or swinging, fighting in their dreams. They don't act them out. Instead, the sleeper only twitches, occasionally making small movements. Now, sleepers with malfunctioning REM sleep, on the other hand, thrash around in their sleep, often hit the people that they're sleeping with or hurting themselves if they act out a dream. This is sometimes called the REM behavior disorder. Now we're going to go ahead and talk about the thermal regulation. So during sleep, the body temperature usually falls by 1 to 2 degrees Celsius during non-REM sleep. During REM sleep, the body temperature tends to increase with the cyclic variability. Alrighty, so now we're going to go ahead and talk about the autonomic nervous system. In general, the parasympathetic activity increases in sleep at sleep onset and continues throughout non-REM sleep. The parasympathetic tone continues to increase during the transition to REM sleep. This increased parasympathetic activity causes a number of autonomic nervous system changes throughout several areas of the body, including the musculoskeletal system, thermoregulation, renal function, genital function, gastrointestinal function, endocrine function, cardiovascular function, sleep-related arrhythmias, cerebral blood flow, and respiratory physiology. Now, talking about the renal function, renal perfusion is decreased during non-REM sleep, resulting in the decreased urine production. In addition, water absorption increases during non-REM sleep, causing a decrease in urine production. Urine production is decreased even more during REM sleep. Alrighty, so moving on to general function, there are few to no changes in the general function during non-REM sleep. In men, REM sleep is associated with penile tumescence, so that's also known as erection. The erection usually occurs at the start of REM sleep and continues throughout the REM sleep phase. In most cases, the erection is lost at the end of REM sleep. Similarly, genital changes occur in the erectile tissue of women during REM sleep. The sleep-related erections develop as a result of the increased parasympathetic activity and local vasodilation that normally occurs during REM sleep. And for the gastrointestinal function, the effects of sleep on the gastrointestinal system are mainly caused by the increased parasympathetic activity, circadian rhythm factors, and central nervous system activity. During sleep, salivation and esophageal motility, also known as swallowing, are markedly decreased. Gastric acid secretion follows a circadian rhythm with the peak acid production occurring between 10 p.m. and 2 a.m. This circadian pattern is mediated by the vagus nerve. Colonic function is also decreased during sleep, which in turn results in a reduced colonic motility. When awakened in the morning, the colonic motility increases significantly. Alrighty, so now talking about the endocrine function. So plasma growth hormone concentrations usually peak about 90 minutes after the onset of sleep. Typically during stage N3, patients with obstructive sleep apnea or narcolepsy commonly have a decreased correlation between sleep and growth hormone concentrations. Adrenocorticotropic hormone, also known as ACTH, and cortisol secretions follow circadian pattern, which typically peaks during delta sleep stage N3. Between 4 a.m. and 8 a.m. Now moving on to the cardiovascular function. During non-REM sleep, the vagal nerve function provides relative autonomic stability. The heart rate and blood pressure variations during non-REM sleep follow a sinusoidal pattern called nocturnal dipping. That is, during a normal inspiration, the heart rate and blood pressure increase briefly in order to accommodate venous return and increase cardiac output. During expiration, the heart rate and blood pressure gradually decrease. The normal cardiovascular rhythm unevens and is a positive marker for good cardiac health. Its absence is associated with increased age, normal vagus nerve function, or heart pathology. During REM sleep, the heart rate becomes variable with episodes of both increased and decreased rates. The heart rate may increase as much as 35% during REM sleep. Alrighty, so moving on to sleep-related arrhythmia. So during non-REM sleep, there is an increased activity of the vagal nerve, which causes a decreased heart rate, blood pressure, and cardiac metabolism. Collectively, these activities reduce the sleeper's risk for cardiac arrhythmia. However, the decreased blood flow during non-REM sleep may lead to myocardial hypoperfusion. On the other hand, the surge of autonomic activity during REM sleep increases the heart rate and blood pressure and increases the risk for heart arrhythmias. Premature ventricular contractions, also known as PVCs, paroxysmal atrial tachycardia, atrial fibrillation, non-sustained ventricular tachycardia, and even periods of cardiac asystole may be seen. In addition, the increased sympathetic activity during REM sleep results in a reduced oxygen supply to demand ratio, coronary vasoconstriction, and variation of both cardiac ventricular preload and afterload. Nocturnal angina, also known as chest pain, is sometimes seen in patients with sleep apnea, as in orthopnea, paroxysmal nocturnal dyspnea, reflecting congestive heart failure. Now moving on to cerebral blood flow. During non-REM sleep, cerebral blood flow decreases. During REM sleep, cerebral blood flow increases. Spinal cord blood flow also increases during REM sleep. In addition, the cerebral blood flow is decreased during post-sleep wakefulness when compared to pre-sleep wakefulness. The cerebral metabolic rate increases during REM sleep. Alrighty, so lastly, we're going to be talking about respiratory physiology. So the intrinsic rhythmicity of ventilation is coordinated by the medulla oblongata, which responds to the neural impulses generated from the oxygen-sensitive peripheral chemoreceptors located in the aorta and carotid arteries, and the carbon dioxide or hydrogen ion sensitive central chemoreceptors located in the medulla. The primary function of ventilation, therefore, is to maintain a PO2 and PCO2 within normal physiological boundaries. Although the precise mechanism is not known, the medulla's ability to respond to PO2 and PCO2 changes is reduced during non-REM sleep. This is especially true in regards of the medulla's ability to react to sudden changes in the PCO2 level. In non-REM sleep, the respiratory rate decreases, causing the minute ventilation to fall as much as 0.5 to 1.5 liters per minute. It is suggested that the reduced minute ventilation is caused in part by 1, the decreased metabolic rate that occurs during sleep, 2, the reduced ability for the medulla to respond to ventilatory signals during sleep, 3, the decreased sensitivity of the PO2 and PCO2 chemoreceptors to send signals to the medulla during sleep, and 4, the increased airway resistance caused by reduced muscle tone in the upper airway. So during REM sleep, the respiratory rate increases and decreases irregularly. This irregular respiratory pattern is thought to be secondary to brainstem respiratory neuron activity. And yeah, that was our presentation on chapter 17. Hope you enjoyed it. Thank you for listening.